Good afternoon. This is a pleasure for me to be here in Qatar. Before I start, I would like to thank Professor Philippe Landreau and Pieter Edog, your kind invitation. Thank you. It's a real honor to join the faculty in this course focusing ankle. I work in Barcelona, and also some part of my time I try to use my time to work with orthopedic surgeons of Pittsburgh. And first of all, what is the reason why I am here today? Why I can make this kind of talk? Only some introduction. One of the reasons, in my opinion, is my point of view of the anatomy. I like to show the anatomy in another way. I have worked in anatomy more than 26 years. Thanks to this experience, I can understand very well the surgical anatomical correlation. Other reason is the anatomical photography. My skills in day life and real life photography were one of the bases of my anatomical work. And this type of image is the key point of my work. I will try to show you during this course. The aim of my talk is to show you some relevant anatomical details of the ankle joint with interest for ankle arthroscopists, in special to try to avoid ankle complications. You can see in this video one surgery. This is the posterolateral portal. This is a surgery performed by an experimented surgeon of Spain, and you can see the problems to obtain a correct direction of this posterolateral portal. Maybe this is not important with the needle make these lesions. Maybe it's not important. After 20 minutes working in the same portal, the surgeon has make big lesion and start to remove all the posterior ligaments. I think this is not a good surgery. The overall complication rate of ankle arthroscopy vary between 3.5 to 20%, with average around 10. In the last publication of Van Dyck and his team on ankle complications, literally says use of meticulous technique can aid in reaching this goal to obtain less rates of complications. But this sentence broke my heart. Where is the anatomy in this sentence? For this reason, we write a letter to editor John Carlson, who has accepted for publication after many Spanish and English corrections, but finally is accepted. The anatomy is very important. This is not my opinion. It's the opinion of many, many surgeons in the most important books in ankle arthroscopy or in arthroscopy, and I think this is the reason I am here today. The anatomy is the importance of anatomy is evident if we note that our work in the KSTA is the most downloaded work in the journal. The anatomy, I think, is very important. But today I will like to show what I call ankle arthroscopy philosophy of the Professor Van Dyck. This philosophy includes knowledge of ankle anatomy, of course, diagnosis, arthroscopic technique, and knowledge of ankle arthroscopy anatomy. We recommend perform the ankle arthroscopy without routine joint distraction. Many studies argue that during arthroscopy, the ankle should constantly be in distraction because to this configuration. It's a load-bearing joint and the intra-articular space is very narrow. Nevertheless, ankle arthroscopy in the majority of procedures, it can be performed better and more effective without routine joint distraction. On the other hand, some authors recommend use a small arthroscopy with distraction or without distraction. But The supply of saline fluid in the joint will be insufficient. In this case, an accessory portal is necessary. But is the joint distraction necessary to perform an ankle arthroscopy? I will try to answer this question. The answer is no. I'm going to justify this answer, but it's no routinely. The answer is supported by surgical basis, anatomical basis. When use ankle distraction, the surgeon is beside the patient. Is not very comfortable for the surgeon. Normally, the pathology is usually located in the anterior aspect of the ankle joint. When distracting the joint make it possible for the loose bodies to fall in the posterior aspect of the joint, thus making removal more difficult. This is important to remember. From the point of view of anatomical basis, if the pathology is located in the anterior aspect of the ankle joint, the distraction has some disadvantage, reduce the articular space and increase the risk of complications. The anterior capsular insertion in the tibia and talus occurs at a distance from the cartilaginous layer. This particularity determines the existence of a substantial anterior capsular recess. When the size of this area depends on the position of the foot. When distraction is used, the tension of the articular capsule increase and reducing this articular recess, anterior articular recess, or anterior working area, according to Professor Van Dyke. Sorry, okay. The same occurs when the distraction and the feet is in the plantar position. The capsule, the anterior capsule, is also in traction. You can see in this anatomical image the ankle in the neutral position. You can see the capsule joint is relaxed, and when the feet, so the ankle is in plantar flexion, you can see the capsule is in tension. You can see in other anatomical views, in the anterior medial view, you can see the capsule in neutral position, is relaxed, and in tension during the plantar flexion. For this reason, we recommend the dorsiflexion of the foot for performing anterior ankle arthroscopy. The surgeon uses his belly for patient foot dorsiflexion. You can see also in this image, we make a some window in the anterior capsule, and you can see the insertion of the capsule, and after in the dorsal position, it's more possible to obtain an anterior working area. When the joint is in dorsiflexion, the talus also is protected within the joint, and the risk of injury of the cartilage when creating the anterior portal is minimized. You can see in this image, in the plantar flexion, it's easy to understand that the cartilaginous lesions will be increased when performing the arthroscopy in plantar flexion, not in dorsiflexion. Also, one of the other disadvantages is when the foot is in distraction in plantar flexion, it increases the tension of the structures placed in the anterior area of the ankle. And also, we have, in our opinion, high risk of injury. The most complication described in arthroscopy of the ankle involve the superficial peroneal nerve when performing the anterolateral portal. But also it's important to remember the relation of the anterior vascular bundle. The injury of the tibial artery may be caused by aggressive anterior synoviectomy, especially when performed anterior ankle impingement. Also, for the placement of the strap placement during the distraction, you remember the distraction can use more than 1 hour, and also the incorrect portal placement. After these options, we hypothesize that the ankle dorsiflexion, the anterior neurovascular bundle, will move away anterior for the ankle joint, whereas in the ankle distraction, the anterior neurovascular bundle is pulled tight towards the joint, thereby decreasing the safe anterior working area. For this reason, with the co-workers of Professor Van Dijk, in our study, a special device was developed. Each ankle was scanned in ankle dorsiflexion and in distraction, and the distance between the artery and the anterior surface or anterior border of the articular surface was measured. We conclude that the distracted ankle position puts the neurovascular structures more at risk for iatrogenic damage when performing anterior ankle arthroscopy. You can see also in this image, you can see this is a typical fat tissue inside the joint, like HOFA tissue. And when the ankle is in dorsiflexion, neutral position. Also, the tendons are in tension. The tibialis anterior tendon, landmark for the anteromedial portal, are in tension. In dorsiflexion, the tendons is relaxed and move laterally, allowing to make the portal more laterally and further away from the neurovascular structures, especially the saphenous vein and saphenous nerve. In fact, the answer should be no, but not routinely. But in some case, we need use the ankle distraction in this special case. But we believe we must perform the ankle anterior arthroscopy in dorsiflexion in all the cases, or most of the cases. Also, to avoid this kind of lesions, of the cartilage lesions or injuries, when working, especially in the tibiotalar space, we can use the small arthroscopes. It's other option with this problem of irrigation inside the joint. Some comments in the relation to anterior portals anatomy. Many anatomical structures during the portals performing are at risk. Especially, the most important is the superficial peroneal nerve related during the anterolateral portal performing. In the work of Van Dijk, the rate of complications is around 3.5% in 43 patients. More or less half were neurological complications, and these neurological complications was related to the portal placement, especially the superficial peroneal nerve. Numerous suggestions have been made to decrease the rates of complications. Good anatomical knowledge, of course, they use the vertical incisions only affecting the skin, parallel to the tendons and neurovascular structures, with subsequent blunt dissection up to the level of the joint have been postulated. The anatomical landmarks of bone and soft tissue in the ankle joint are easily palpated and should be delimited in the patient's skin with the dermographic marker. Landmarks are essential for proper positioning of the portals. Remember, if you use distraction, it's necessary to delimitate in the patient's skin the landmarks after the distraction system is applied. The superficial peroneal nerve, you know, are the only nerve in the human body can be made visible. Preoperatively identification during the inversion of the nerve assist in preventing iatrogenic damage during foot and ankle arthroscopy. You can see in this dissection, this superficial peroneal nerve, as you know, after make a hole in the fascia, is divided into branches. This is a medial branch and this intermediate branch. The intermediate branch is the most important, but this is in relation to the anterolateral portal. Remember the position of the nerve when we have inversion position. This is the moment we can see the nerve, but the ankle position is in dorsal flexion. Maybe it's not important to identify the nerve during the ankle arthroscopy is more important when perform open surgery. But remember, if you make a reference in the skin of the patient in inversion, remember the nerve move laterally, and you need to change, or you need to in mind this concept. Vascular landmarks such as the great saphenous vein withdrawn in front of the medial malleolus is also important to identify in order to avoid injury during the anteromedial portal. The reason is the many different small communications between the deep and superficial venous system. Also, it's very important to know the standard instruments and the specific instruments in order to avoid this kind of complications. But what portal must be done? Remember this date, we can consider the date of the revolution in ankle arthroscopy. Before 2000, numerous portals have been described for arthroscopy of the ankle. Even though a large number of portals were described, the access to the posterior region of the ankle was unsatisfactory. Some of them, all of these portals, are not recommendable because they are difficult to perform or have a high risk of injury. But until this point, the majority of procedures can be made with 3 portals: anterolateral, anteromedial, and posterolateral portal. But after the paper of Van Dyck, he describes 2 new portals in the ankle arthroscopy. Reality, in my opinion, is the way to make these portals is different than described with Watanabe, but he opened a new area of work in ankle arthroscopy. Remember the last sentence of the paper of Van Dyck: arthroscopy of the ankle is a therapeutic and not a diagnostic procedure. I think this is very important. Given that it is a diagnostic suspicion supported by numerous complementary examinations that determine the indication of arthroscopy, it seems reasonable to adopt a separation of arthroscopic pathology of the ankle into posterior compartment, pathology of the anterior, and pathology of posterior compartment. For this reason, we can divide the arthroscopy in ankle in 2 compartments. In the pathology of anterior compartment, you use 2 portals, anteromedial, anterolateral, and for the pathology of posterior compartment, we use the portals described by Professor Van Dyck. We see the major anatomical details of the anterior portals. The anteromedial portal is the first portal to be performed. It's established just medial to the tibialis anterior tendon at the level of the ankle joint. This is the tendon of the tibialis anterior tendon. And there is a potential for injury of the saphenous nerve and great saphenous vein. We see this before. This is the small veins. We can make a lesion during the portal. This is important for this reason. Use a correct technique. The notch of Harty maybe allows easy access to the posterior ankle joint. I am not sure this is very important in arthroscopy, but you can see constantly during the normal examination of the joint, and we can see during the anatomical dissection, this notch maybe facilitate the access to the posterior area. The anterolateral portal is creating the anterior joint line just lateral to the peroneus tertius tendon. The peroneus tertius tendon we can consider is a constant tendon. It's a constant muscle. It's more easy to see than don't see. This is the peroneus tertius. And the anterolateral portal is created by outside-in technique with control of the anteromedial portal, the arthroscopy in the anteromedial portal. When performing this portal, the main structure at risk of injury is the intermediate dorsal cutaneous nerve. This is a superficial peroneal nerve every time, and I think it's very important you remember this is the most complication described in ankle arthroscopy. in relation to the posterior portals, two portals, the posterior endoscopic portals. In this sentence of Professor Van Dyck, it is recommended that the procedure be performed by experienced arthroscopists. This is important, I think, to remember. What is the limit for posterior hindfoot endoscopy? Is our anatomical knowledge. I think this is very important, and this knowledge must include the arthroscopic anatomy. We must to recognize this kind of image. This is very important. Normally, it's some different anatomical position. This is very important. The surgeon understands very well how is each structure. And look at this image. This is some special image, and this is image in relation to two tendons in this area. You remember the flexor hallucis longus is the main structure landmark in this area. In this case, in this video, Jorge Pablo Batista is a surgeon from Buenos Aires, has two tendons. Maybe this is a flexor digitorum accessorius longus. I am not sure, but it's very difficult. The literature is not clear, but if this muscle is the second most common accessory muscle in the ankle, and normally it's asymptomatic, but if you see this and you don't have the possibility to recognize, maybe you have some kind of disorientation, and you remember this is a flexor, it's medially to this flexor exists the neurovascular bundle, and this is very important to remember. Also, our arthroscopic technique skill is another of the limits in the hindfoot arthroscopy. This cutaneous landmark is very important too. This is the most important landmark. This is the tip of the fibula. The portals is in relation of the line parallel to the sole of the foot, and the portals is near to the Achilles tendon. The first portal is in this case is the posterolateral portal, and remember this portal is in relation to the Achilles tendon, and in this case the posterolateral portal is in relation to the Achilles tendon, the sural nerve, sorry. The sural nerve is a different percentage of lesion. You need to remember this nerve. You can see in this transversal section, and another time, this is very important, the technique. This is the way to perform the ankle arthroscopy. In the posterior ankle arthroscopy, I don't explain this. I am sure you know very well, or other speakers explain about this. But the most important is to remember is the point to the first image of posterior ankle arthroscopy. This is the good position of arthroscope in the posterior subtalar recess. This is very important. This is the most important reference. This is the first image, is the subtalar recess. This is this area, and this sagittal section. This is the typical image. And one of the most important reference too is the posterior talofibular ligament. The posterior talofibular ligament is a very important landmark. Above is located the talocrural joint. Below, the located subtalar joint. This is very important. You can see also in this other part of the image, this is the posterior subtalar recess, this is ankle joint, and this is the image of this ligament, the posterior, the talofibular ligament. You can see below and above is the limits of the ankle joint and the subtalar joint. And this is a typical image of this ligament during posterior ankle arthroscopy. But to reach this point, the periarticular fat tissue and Caher fat pad should be removed. During this process, this kind of image, facial fibers that have a transverse course and a consistent appearance can easily be recognized. These fibers are part of the deep crural fascia, that because the constant movement of the ankle is considerably thickened at the level of the ankle joint. You can see this part is more thickened than the other parts of the fascia. What is this? But Rouvier, anatomist of France, explained about this fascia and gave this structure the name of the fibulo-talocalcaneal ligament. This is important for orthopedic surgeons. It's not important maybe to remember the name, but it's important, but this is a thickened part of the fascia. If you don't make a hole in this fascia, you don't arrive in your working area. And this is very important. It's difficult to define the limits of this structure of this ligament. You can see other dissection. Also, this ligament is the floor of the fibularis tendons, peroneal tendons. Finally, with the knife, we decide this is the level of this ligament. I am not sure. It's very variable. But you can see during the endoscopy, you can see these fibers. If you don't remove this and you make a hole here, it's very difficult to work in this area. You can see this hole. This is a video of Professor Van Dyck. And also the first image is this ligament, is the posterior talofibular ligament. You can see distal is the subtalar and proximal is the ankle joint. And after this fascia, the next step is this area, the tendons, the deep tendons, and the neurovascular bundle. The flexor hallucis longus tendon acquire special relevance because the tibial neurovascular bundle is located medially. This is very important. Our working or safe working area is every time lateral to this tendon. And you can see in this anatomical dissection, this is the flexor digitorum longus, this is a retinaculum, this is a posterolateral process of the talus, this is the subtalar ankle joint, this is the posterior talofibular ligament, this is an intermalleolar ligament, calcaneofibular, and this is our working area. This is very important during the technique. The first reference to see is the posterolateral process and the flexor hallucis longus. This is very important. And this is the typical image you can see during the ankle arthroscopy, posterior ankle arthroscopy. Remember, the proper position of the ankle and the hallux results in better visualization of the tendinous spar. Remember, the muscle belly is in this way, is a semi-peniform way. The plantar flexion of the ankle or the flexion of the hallux is perfect to see the tendon at the level of the posterolateral process. We don't need to clean much the tendon and muscle. It's only one reference, only in the case we have a tenosynovitis. But you can see the relation of the flexor hallucis longus with the nerve. This is the division of the tibialis nerve in the medial plantar nerve and lateral plantar nerve and the medial calcaneal nerve. If you clean a lot, maybe you can make a lesion of the medial calcaneal nerve or the main trunk. This is very important. And after this, we see that the flexor hallucis longus. What is the next step? The next step is the capsular ligamentous joint area. This is very important. We need to arrive at this level. We can open this thin capsula with some reinforcement. I explain tomorrow. This is the intermalleolar ligament. But the most important for my message is you need to remember how is the anatomy and how is the anatomical image. This is very important. If you know this very well, the technique is more easy and the complications is more difficult to make. Thank you very much for your kind attention.